How's it going, guys? We have a difficult question for pharmacology. If you've been following my content, maybe you think this isn't hard, but for many of you, it's hard. Okay, so you have a 64-year-old dude. He has left heart failure, and this is evidenced by his pulmonary edema here. Cephalization of pulmonary vessels is a buzzy phrasing on USMLE that just means pulmonary edema. They can say bat wing appearance, it's the same deal. If you have left heart failure, it backs up to your left atrium, and in turn that's going to back up to the pulmonary circulation, increase pulmonary capillary wedge pressure with hydrostatic pressure, extravasation, transitation into the alveolar spaces, which is why we have the pulmonary edema with the crackles here. Doesn't have diabetes, non-smoker, two important negatives, but he has dyslipidemia and hypertension. So the hypertension is going to be backing up onto the left ventricle, which is what's causing the left heart failure here. The concentric hypertrophy occurs during exposure to afterload over time. So concentric sarcomeres laid in parallel, afterload, S4 heart sound. In contrast, eccentric hypertrophy from high preload, S3 heart sound usually. So we're just asking, what's the next best step of management in a patient who has reduced ejection fraction? Correct answer is choice D, lisinopril. So this is what you got to know for 2CK3. If you're studying for step 1, relax, you got to ace 2CK eventually. What USMLE wants is an ACE inhibitor or an angiotensin II receptor blocker as the first step for heart failure, both reduced ejection fraction as well as preserved ejection fraction, most of the time. Okay, are there exceptions? Absolutely. We're talking most of the time. So lisinopril could be candasarin, doesn't matter. They're used interchangeably, but it's to my observation, USMLE really likes lisinopril. So you give an ACE inhibitor or an ARB first. Now there's two reasons for this. Number one, you can say, well, ACE inhibitors and ARBs decrease cardiac remodeling, they decrease mortality. That's true. But also mechanistically, it makes sense. Because if your left heart is failing, it makes sense that you're not perfusing your kidneys the way you're supposed to, right? And in turn, the kidneys will think that you've got reduced blood volume, and renin-angiotensin-aldosterone system will activate. So you're going to have higher angiotensin II in the setting of left heart dysfunction. Angiotensin II is a potent vasoconstrictor, not just at the efferent arterioles leaving the kidney, but also on systemic arterioles. So by giving an ACE inhibitor or an ARB, we attenuate/mitigate the effects of the AT2 on the peripheral arterioles, decreasing their constriction, thereby decreasing afterload in the left ventricle, thereby enabling increased ejection fraction. So mechanistically, we just knock out RAS, and that's going to help us improve the ejection fraction by decreasing afterload in the left ventricle. Makes sense? So that's why we like ACE inhibitors or ARBs first. So after the ACE inhibitor or the ARB, you can add a beta blocker if a patient has persistent decreased ejection fraction. Even with preserved ejection fraction, you can go to beta blocker next. Now, bisoprolol, carvedilol, nebivolol, metoprolol extended release, those are a classic 4 beta blocker selection that they decrease mortality and heart failure. Now, it's not that you have to specifically memorize. The USMLE is not going to say which of the following beta blockers decreases mortality and heart failure. That's not what they do. I'll tell you what they do as per my observation. They'll sometimes give you a vignette like this, and they'll throw in propranolol as an answer. And if you know that propranolol is not one of the typical beta blockers used for heart failure, it's easy to eliminate it. Okay, so you say, well, would we use a beta blocker here? Well, maybe, but propranolol is not going to be the one we use. In this case, bisoprolol, even though we could use it in heart failure, decreased mortality, we want to start the ACE inhibitor ARB in most patients. Okay, so we go lisinopril first, we can add the beta blocker. After that, we can add spironolactone, which is an aldosterone receptor antagonist, decrease mortality and heart failure. Obviously, it can cause things like gynecomastia. There's risks with all these medications. There's things to consider, patients who have renal insufficiency, advanced diabetes. There was a question on one of the new 2CK NVMEs where they actually go to a thiazide over spironolactone for that reason. They want to decrease the risk of hyperkalemia. It's a little bit weird because thiazides, in theory, can cause insulin resistance and hyperglycemia, and you notably would prefer to not use them in diabetics, but it's a very difficult question on a new 2CK NVME, and it gives everyone a headache. say, why the thiazide? Why aren't we using spironolactone? Hyperkalemia risk with renal insufficiency in some patients. So this is what I want you to know so far. For heart failure, you're going to start with the ACE inhibitor ARB, okay? Then you're going to add the beta blocker. Then you're going to add spironolactone or eplerenone. Then in blacks only, that's what the guidelines say, okay? You can add the combination of hydralazine and nitrates, okay? So that's something to know. And then if that still doesn't work, you can add drugs like digoxin. Digoxin does not decrease mortality in heart failure. I want you to know that. Step one, you need to know the mechanism that digoxin inhibits sodium potassium ATPase pump. So potassium can't get into the cell, sodium can't get out of the cell, sodium's building up in the cell. That's going to cause an indirect inactivation of the calcium sodium antiporter ATPase pump, where sodium's not going to want to come into the cell, so calcium won't be able to leave the cell. Calcium stays in the cell. Greater contraction, so it increases inotropy with digoxin, also slows your heart rate. You should also know that loop diuretics, furosemide, can be used early on. So we said lisinopril and bisoprolol is the starter, but you can also throw furosemide in there to make a patient euvolemic. If the focus of the vignette, and this is where it can get tricky for 2CK3, if they give you a 12-line paragraph for heart failure where 11 out of the 12 lines are hyper-emphasizing how the patient can't breathe. They say the oxygen sats are 84% on room air, and there's crackles heard 3/4 of the way up both lung fields, and the patient refuses to lie down in the gurney because they say they can't breathe. If the whole vignette is about how the patient can't breathe, they want furosemide over lisinopril. You have to use your head, okay? So the focus is the patient can't breathe. You're going to fluid unload the patient with the loop diuretic. If they have severe peripheral edema, you unload them with the loop diuretic. If that's the focus of the question. If they give you just a little bit like this, in this case, say, oh, there's bibasilar crackles. The fluid unloading isn't the overwhelming emphasis. It's the ACE inhibitor that they want. Spironolactone, wrong fucking answer.